Colorectal cancer kills, but in many cases, it can be prevented. Welcome to SBH Bronx Health Talk, produced by SBH Health System and broadcast from St. Barnabas Hospital here in the Bronx. I'm Stephen Clark. March is Colorectal Cancer Awareness Month, yet people need to be aware throughout the year of the risks of colon and rectal cancer and what they can do to prevent it. Screening is key. This includes a colonoscopy beginning at the age of 50. A colonoscopy allows doctors to find and remove polyps, benign non-cancerous growths, before they can become cancerous. With us today to discuss colorectal cancer is Dr. Michael Polcino, a colorectal surgeon at SBH Health System. Welcome, Dr. Polcino.
Thank you, I appreciate it. So
let's start off. Who is most likely to get colorectal cancer? I mean, there are common risk factors, right?
You know, if someone has risk factors, it might be they have bleeding, rectal bleeding, there might be a change in their bowel habits. We often describe as patients say their bowels used to be in large caliber, this large diameter. Now they're very, very thin. That's also a telltale sign. Also, if they have some weight loss is another sign. But really, that's more advanced. That's more advanced in bigger tumors. Oftentimes, cancers are found just on screening. And actually, Steve, I'd like to point out is traditionally screening used to begin at age 50, but it's now age 45.
Really?
Yeah.
Okay.
Yes, this changed about 2 or 3 years ago, and the reason it moved from 50 to 45 because there was a large incidence of colorectal cancers in that 45 to 50 age range, and we're not really sure what is it genetics, is it environmental? We're not really sure. What happens is that's why we moved the screening up to age 45.
Okay, but from what I've read, African Americans are more likely to get it. I read they're like a 20% more likely candidate for colorectal cancer. Have you seen that in the Bronx?
I have, but also what I found is patients aren't getting their screening, and so they're coming to me at later stages where tumors are more advanced. That's why really the whole secret to have good results with colorectal cancer is get your screening, get it early and on time.
Are there certain lifestyle changes you can make to improve your chances of getting colorectal cancer?
You know, sometimes there's some studies that show red meat is associated with higher risk of colorectal cancer. What I tell my patients is a well-balanced, healthy diet is the best for reducing the risk of colorectal cancer, the best for heart disease, the best for reducing the chance of diabetes. A nice, healthy, balanced diet is the best for just health overall.
Okay. Now you're obviously a surgeon, and you would think if screenings were effective, people like you would be out of business. But that's not happening anytime soon. In fact, I read that the number of colorectal cancers in people under 50 is expected to nearly double in the next decade. What gives? Why is that?
That's, again, a couple of things. There's interplay of multiple factors. One is, we think, environmental, is the foods we're eating they're more processed foods, not as natural. That's one thing. And also, we're finding things earlier because if patients are getting screened a little earlier, we're finding things at age 45, age 46, age 47, which in the past wouldn't be found in their 50s.
Okay. Now, you said earlier that some of the symptoms of colon and rectal cancer are bleeding, but really they're pretty mild. I mean, it's not like you wake up and say, "Gee, I have colon cancer." It's not that significant, right?
No, it's not. Patients, they might see a little bit of blood in their stool, might be a little bit of blood in there, in the toilet bowl, but not like it's all blood and that when they would go to the bathroom. So the symptoms, they can be very, very mild. And I tell patients, this is my practice. Any bleeding, just get the colonoscopy. You rule everything out. It's the safest thing to do. No questions asked.
Do you get pushback about having colonoscopies? I mean, it's not the most pleasant experience. At least the prep is not. Are people hesitant to do it because of that?
You know, the biggest reticency and hesitancy is from the bowel prep, because it's not pleasant. I'm not gonna lie, because it's one night, and again, you're gonna go to the bathroom a lot. but it saves lives. So I always say one tough night can save a life.
Okay, it's a good way of putting it. So what happens when someone is diagnosed with colon cancer? Is surgery always part of the treatment? Or typically?
No, happens is I think the secret with the treatment of any cancer is to treat it as what's called in a multidisciplinary fashion. Me as I'm the chief of colorectal surgery here at St. Barnabas. I run the colorectal service, but I work very closely with my colleagues, with my medical oncologist, my radiation oncologist, my gastroenterologist, and my radiologist. We work very, very closely all together. What happens is it's a true team approach to the treatment of these cancers. Sometimes we might go right to surgery. Sometimes we might give chemotherapy, radiation first. It all depends. How advanced the tumor is, where the tumor is also a big determinant.
Okay. My father had colon cancer in his late 70s, early 80s, and he had a colostomy, which he had a bag, which was later reversed. Now, at the time, I mean, he was demented. He was into probably advanced Alzheimer's at that time. So it was really difficult for him to comprehend what was going on. Are there less invasive surgical techniques that are being used today?
There is. What happens is if it's a large obstructing tumor, if it's distal, then a colostomy still might be necessary. But again, there's so much nuance in how we treat colorectal cancer today versus even 10, 15, 20 years ago. Sometimes if the tumors are early stage, we can sometimes even remove them through the colonoscope or through the endoscope. I do a lot of minimally invasive surgery. We do a lot of laparoscopic surgery, small incisions. Patients go home in a couple of days. Those are a couple of things how we're doing things. And again, if we can, we always try for what's called sphincter sparing surgery to try to avoid a colostomy.
Okay, so colostomies are not the go-to or not the gold standard anymore. What percentage would you say we use other options?
Oh, I would say 85, 90% we use other options.
Oh, okay.
It just happens. The question is, when do you make a colostomy? That happens if it's a big obstructing tumor where we can't safely do the reconnection in the first surgery. That's sometimes where we have to make a colostomy.
Okay. Okay.
But
I read something about.
Actually, one more point is I think this is probably important to discuss is patient. Even though again, I always try to avoid stomas, ileostomies, colostomies. Patients shouldn't be scared of stomas. Happens. I always tell patients, a stoma is safe surgery. If we feel you need a stoma, we want you to get out of the operating room. We want you to get on treatment, chemotherapy or anything. We don't want any treatment delay. And oftentimes these are reversible. So I think there's a stigma against a stoma, but the secret is the stoma is safe surgery.
Okay, I think that's a good point. I read about targeted therapies. Is that something like, for instance, I read about monoclonal antibodies, which are used in COVID treatments. Is that something that is here today, or is it in the future?
No, it is. What happens is we have standard arm. And this is more the expertise of the medical oncologist. We have standard art chemotherapy, which often is called FOLFOX. What happens is whenever we do a colon, either colorectal resection, we send the tumors for a special gene typing, and depending on those genes, if they're what's called wild type or mutant, they can get immunotherapy. And targeted therapies is a good way of describing it.
Okay. I guess, again, ending now, bottom line, screenings. You got to get your screenings. Is that fair?
Exactly. The secret to good long-term care, good long-term survival for colorectal cancer is get your screening, get it on time, and get it early. And remember, age 45, not age 50.
Okay, that's very good advice. Thank you, Dr. Polcino, for a few minutes today. I really appreciate your time.
Great. Thanks so much. Have a great day.
Okay, and to our listeners, thank you for joining SBH Bronx Health Talk. For more information on services available at SBH Health System, visit www.sbhny.org. Until next time.